So, good afternoon, everyone. Today, we will going to discuss a very important but often a neglected topic in critical care, that is ICU delirium. And some of us also call it ICU psychosis, but is it right to call it ICU psychosis? What is the incidence of ICU delirium? What are the risk factors? And what are the things that you can prevent it? What are definition, all, etc., etc. Or to discuss all these things, today we have Dr. Rakesh Periwal, who is a good friend, and he is physician and consultant in critical care in Apollo Hospital, Guwahati. He is very active academically and very good speaker. So it will be really excited to to listen to him. So over Dr. Rakesh, please.
Thank you so much, Saurabh. Nice to share this session with you. We kind of studied together and now we are studying
turn on
video.
Video. Your video is off, Rakesh.
Video is on only. My slide camera, is not visible.
The slides are.
Oh, camera, okay, camera you cannot see because I'm on mobile.
Okay.
So talking on, it's more for a discussion rather than explanation because things are simple and things are difficult. That's how delirium is. If you look at the DSM definition of delirium, it's an impairment in attention and awareness that develops over a relatively short time interval and that is associated with additional cognitive deficits. So if you look at the definition, talk about an acute onset of altered sensorium. So when the patient reaches the hospital in the emergency room or in the ICU, he is conscious oriented and this documentation should be very, very clear. And somehow during the course of the stay, the patient has an acute confusional state. Very rarely, we may have a very good history where the family tells us that the patient has an altered sensorium for a few hours now and has been brought to the emergency room. The only difficulties in such situation is whether it is delirium or is it a metabolic encephalopathy, because when we diagnose delirium, we generally call it like a diagnosis of exclusion. Well, all other neurological issues have been ruled out. Only then we attribute the altered senses to delirium. So it has to be acute in onset, something which happens over hours or days, and it can be timed. When did it happen? And there is an impairment in attention and also awareness about the surrounding. The patient may be disoriented. He may not know where he is, what he is doing, why he is there. And the cognitive deficit part has to be documented. And this is, we generally do it by some questionnaire or by looking at the organization of thinking in the person or the reaction. If we look at very simple terms, delirium is a condition in which a patient is awake, fairly alert, but he's confused. We can take patients who have a little less alert, like a RAS score of -2 to -3. So someone who is still responding to verbal commands, but not making eye contact. He's not responding to you. He's not talking. Even that category can be included, but beyond RAS -3, we do not entertain delirium. On the other side, if we have a RAS score of even +5, where it's an agitated combative patient, we will consider that as delirium. So we have this alertness part in two spectra, one in which the patient is slightly drowsy and inattentive, and the other side is more restless. Oh, it's very vivid, and patient is confused. The confusion is the most cardinal part of everything. And we have to look at both the content and the level of senses. The level of sensorium is what we match it by the RAS scale, and the content is what we do by a questionnaire or by an interview or by asking the patient to do something. And the other hallmark is fluctuation. So the sensorium doesn't remain the same, or the confusion is not static. It keeps changing. And we do find these situations where the staff nurse tells us the patient was confused and the other nurse tells, no, patient was not confused, he was cooperative, but that is how delirium is. It can keep changing. So the documentation should be very, very good. Otherwise, we will think the staff is confused. So it has to be written in very clear terms of what was documented, what was the area which was deficient, And it does happen sometimes that the delirium resolves once you kind of reorient and talk to the patient. So that can also happen. Fluctuation is another part, which is almost an essential aspect of documentation. And even in terms of the level of senses, there could be a fluctuation where the patient on one end is drowsy and on the other end is extremely agitated. That can also happen. So that is why we have this broad definition, this classification of delirium into hyperactive delirium. It's very easy to pick. The patient is restless, abusive, combative. He may not follow you. He may pulls on his lines and catheters, may try to run out of the bed, may be throwing things here and there, spitting on you, abusing. That is the kind of. And on the other spectrum, you have a hypoactive delirium, and this needs very keen observation. It is believed the incidence of hypoactive delirium is almost equal to hyperactive delirium, but it's difficult to pick. Sometimes it may not be very important to pick because it's not very disturbing to the nurse, but we need to understand that it has consequences in terms of outcomes. It has been seen that patients of hypoactive delirium do worse when we follow up them at 6 months or so. So both the spectra need to be looked at. And then we have the mixed part, the most common type, where at one end you may have a patient who is hyperactive at one point of time, and then at another point of time hypoactive. Some hypoactiveness may be due to a drug which we have used to control the hyperactive state. So the fluctuation can also be due to the management of the patient. Now let us look at an example. A 70-year-old gentleman with no comorbidities presents with a fracture of neck or femur, undergoes a hip replacement surgery, and a second post-op day, patient becomes agitated and confused, becomes uncooperative and even combative. Here the diagnosis is very clear because we have a patient who is conscious oriented and now has an acute onset of altered sensorium, does not have any comorbidity. It's unlikely that he had a new neurological event now. Such patients are common, and such patients are very easy to pick, especially if they are hyperactive. But clinical situations can be very challenging, and we will talk about that. What are the major causes of delirium? It's old age and major illnesses. Major illness here would mean either surgery or any medical illness which is severe enough to require ICU admission. If we compare the incidence of delirium between ICU and non-ICU patients, it is significantly more in ICU patients. The incidence can be as much as 20-25% to 70-75%, depending on what is the kind of patients which are there in the intensive care. Those who are ventilated with multi-organ failure, elderly people, prior cognitive deficits, they are more likely to have manifest delirium during the stay in the ICU. Cognitive impairment from before is also a concern, and this cognitive deficit actually worsens with the hospitalization. Sometimes this may not be noticed by the family or may not be recorded in the history sheet because it was not very disturbing. But when we call them again, talk to the family and ask about this mild cognitive impairments, we might get a history where the patient has become forgetful, has problems with language, calculation, judgment, a little impairment in intelligence, or maybe deterioration in personality, socialization. All this could have happened. So background cognitive impairment added to an elderly age where it is very common is a significant risk factor for the development of delirium. Then we look at drugs, especially if the patient are taking psychotropic agents or drugs which have neurological side effects, sedatives, toxins at times. Substance abuse, the most common here is alcohol, or maybe it could be opioid or any other substance. Here we have both the problems of intoxication as well as withdrawal. Probably if it happens after hospitalization, 2 to 3 days down the line, it's more likely to be withdrawal. Most of the drug and alcohol withdrawal might start manifesting itself in 24-48 hours. People who are malnourished and who have deficiency states, classically is thiamine deficiency. We have the Warnick encephalopathy, delirium tremens in alcoholic patients. They are more likely. electrolyte imbalances as well, and patients who develop a disturbed sleep cycle is not uncommon. And in the ICU, it is even more manifest because the environment is not conducive to sleep. There are disturbances both because of care of the patient and those nearby. And we know we have all the lights and sounds going on. It's a 24-hour unit which is active and may not be conducive for sleep. So these are the major risk factors, but the risk factors are endless. If you have a very young patient developing delirium, always consider substance abuse and withdrawal. Always look at if they have been taking some kind of drugs, which the family may not have noted, especially sedatives, because this use is not uncommon in the young people. In the elderly people, it could be a mixed bag. It could be so many things together: cognitive impairment, use of drugs, malnutrition, disturbed sleep, underlying depressive disorders, or maybe electrolyte imbalances precipitated by clinical condition or by drugs. So it could be a mixed bag. And the idea of identification is basically to kind of find out if there is any uh, factor which can be corrected so that the delirium resolves. Now, once we have noted that there is some disturbance in the consciousness or in the content of consciousness, then we need to go to a pathway where we can establish the diagnosis. One of the most common scores used is the CAM-ICU score. It looks at 4 points, and many people also use the ICU delirium index, which can also be whichever you want to use. We use the CAM-ICU score here, and the 4 domains where it looks into is acute and fluctuating senses, inattention, altered level of consciousness, and disorganized thinking. And we need to have problems in more than one domain. So it's generally 3 or more domains they have affected. Then we will say that the patient has delirium. And there should be no alternative explanation for the condition. Although easily said, I'll just give you an example. You have an alcoholic patient with chronic liver disease who we suspect to have hepatic encephalopathy, is admitted to the patient in slightly sedated state. He has been consuming alcohol, and 24 to 48 hours of hospitalization, he becomes agitated, confused. There is a clear-cut change in the senses from what he came with, but it's very difficult to label them because it could be worsening hepatic encephalopathy. It could be the effect of other medications which the patient has been exposed to. It could be just the severity of illness. They might have a pneumonia, another infection, or it could actually be alcohol withdrawal. It is important sometimes to know the etiology from the point of management as well, because alcohol withdrawal, we might require a benzodiazepine as a drug of choice, something which we actually try to avoid otherwise in the intensive care unit because of its strong association with delirium. Now we go back to the previous patient and look at what if this elderly gentleman also had a depressive disorder? What if he also has a chronic obstructive airway disease and is hypoxic? What if he also has a CO2 retention, which is actually worsened in the post-operative state? There, it could be a mix of metabolic encephalopathy and delirium, or it could just be metabolic encephalopathy. It's very difficult to label sometimes. So one cross-sectional assessment may not be enough. You may have to see the patient again and again. And our main focus is how is the delirium impairing care, because that is what is the most affected, the care which is provided to the patient. So delirium diagnosis can be very challenging to pick it up in the first place, especially for patients who have hypoactive delirium, and actually tell that there is nothing else happening which could explain the neurological deterioration, and it's actually delirium. Because if we consider any metabolic cause, then there could be a battery of tests which we might order, imaging, blood tests. Whereas if we are very confident about the diagnosis of delirium, we do not need any corroborative tests. So all the testing in these patients are done from the point of view of excluding another cause, or maybe sometimes identifying a cause for what could have precipitated the delirium. Once we have suspected, we establish the diagnosis, and also we can look at the severity of how much problem is the delirium causing in care of the patient. Common is very common, so it's something which we come across, and although acute in onset, it may last for days to weeks and has short-term and long-term consequences. Generally, when we pick up delirium in patients admitted in our ICU, we follow them all throughout their course of illness, even if they go out of the ICU, stay in the ward, and at the time of discharge, we make sure that we look into their delirium component, explain it to the family that maybe this can have implications after he goes back home, especially for people who already have cognitive deficits from before. There could be a worsening of them. And we try to telephonically look over them at a period of 1 month. So that is a part of our protocol, which we follow because we understand that the delirium, although acute in onset, may be short lasting in certain patients. In some of them, it could be long lasting. It could have implications even after the discharge of the patient. So that is the importance of delirium for the patient, not only for the acute healthcare condition for which he was admitted, but also after discharge. And one of the biggest challenges in acute care, at least for the nursing point of view, I think it is the biggest challenge. And challenge is both in the diagnosis as we talk and also in management. It's easier to manage a sedated, paralyzed, ventilated patients than an abusive, awake, restless patient who is tossing around, refusing medicines, not taking food. It's very, very difficult, not only for the nurse, for even patients who are by the side. We often get complaint from nearby patients that they have not been able to sleep because of an agitated patient nearby. And if you look at the incidence, it's fairly high. So it's a big load that the nurses will have to be managing. We put it as almost a nurse-centric problem because the identification is done by the nurse, the assessment is done by the nurse, the management, although directions may come from the doctor, the evaluation again has to come from the nurse. The titration of medicines, if they have been used, again has to be done by the nurse. She has to know what target has to be reached. We don't want to over sedate our patients because it doesn't look good, something which is not permissible even to the family. We have to communicate it to the family. An agitated patient in the ICU doesn't look good even. And it really bothers you because if they're starting to put lines and catheters, you may have to redo procedures and caregiving may become extremely difficult. The increased costs and length of stay, potential for harm, both to self and to provider. So if somebody pulls on their Foley's catheter, a male does, there could be urethral injury, which could have long-term repercussions. Somebody can pull their central lines and bleed, their arterial lines. Somebody can accidentally extubate themselves. They can pull out their Ryle's tube. They can get their implants removed. We generally do see all of these happening. And also sometimes they can harm the caregiver. There could be needle stick injury because you're dealing with an agitated patient, or there could be spillage of blood or body fluids. Caregiving may be a problem. Perineal care is very, very difficult. So if they pass stool, it's very difficult to clean. They may have to be catheterized just because they are bedwetting. So there could be a compromise in care because a lot of time is now given to just managing the issues which have cropped up due to delirium. And one of the major compromises in care is actually administration of medicines, especially if they're oral medicines. They're not IV. And IV medication, one of the major problems is if they remove their access. Sometimes we do find patients in delirium who do not have any IV access because the IV access which they had, they removed either central line or peripheral cannula, and now cannulating them in the acute agitated state is very difficult. There is clinically worse outcomes. There's no question about it, even for the hospitalization part as well as post-hospitalization. They can have worsening of their previous cognitive deficits, or this could be the first onset of dementia in those patients. So we need to make sure that we manage our patients well. Generally, the dictum is do not discharge them on delirium. Make sure that the delirium resolves to a manageable or maybe pre-morbid condition before we discharge them from the hospital. And dissatisfied family. That is true. If the family sees the patients are agitated, they are restrained physically, or somebody is using sedatives to quieten them, they do not feel good about it. We do take consent for all physical restraint, but we still do not take consent for chemical restraint. But we do explain the family that we might have to use a sedative or a tranquilizer. And when we use these terms, sometimes the family doesn't feel good about it. They will tell you, no, no, doctor, you manage it some other way. Or they might tell the staff, no, no, you employ some other measure to make my patient quiet, but don't give him any drug, because they do not like it. And that is true. Do we have such instances? Yes, where the family actually refuse a sedative to be administered to the patient, whereas we may require it very, very strongly. And the scene is also very visually disturbing, not only for the family, for the staff, but all the visitors to the ICU. You know, even visitors who are not related to the patient. It looks very bad when someone is shouting and howling and his hands and feet are tied. It looks inhuman even. And these are the conditions who patients who require physical restraint. Now, physical restraint, if we talk about my hospital, most accredited hospital, you will have to look for a consent. You will have to look for a timeout for the consent. The validity remains for only 24 hours. Even if the attendant is not present, we have to telephonically call them, take a consent over the phone. And once the restraint starts, we have special restraint monitoring tools in place. So you have to look at the skin, the distal perfusion, the need for the restraint, which side, both legs, both hands. Sometimes we may have to tie somewhere in the mid thighs as well, because they are moving around in the bed. They are at greater risk for falls. And as a rule, we do physical restraint to the least possible. We generally would employ chemical restraint, but sometimes when the agitation is so acute that the patient is jumping out of the bed or is pulling on things, then we might have to restrain them acutely then and there, both physically as well as chemically. So we might have a need for an acute control, and this can be done with drugs. And generally, most of the drugs which will be employed for the management of delirium acutely would be either intramuscular or intravenous. We also have mucosal sprays available now, like a midazolam spray we sometimes use, so that if patient who does not have an IV access, or some of this subcutaneous absorption takes a little faster, time of action is a little fast, so we may employ these alternative routes also to attain a faster control. But invariably it is an intravenous or an intramuscular drug. Which are the drugs? Benzodiazepines, ketamine, although ketamine is known to cause delirium when used for short procedures, but for acute management of manifest delirium, ketamine is one of the drugs which can be used, and people have used this in fairly higher dosages in the intramuscular form, something around 200 to 250 milligrams to up to 500 milligrams even. That's a fairly high dose of ketamine used outside hospital setting as well. One of the most common drugs which is used in the outside hospital settings when the patient is being transferred from some facility to the hospital, mainly because it does not cause respiratory depression. So that is one of the major benefits of ketamine. And hemodynamic instability doesn't cause. It can actually cause tachycardia and hypertension on the other side, but it generally doesn't cause hemodynamic compromise. So in the emergency room, ketamine is one of the most favored drugs. Even in the ICU, we use it very often, and we use it intravenous as well, but it can be used intramuscular if you do not have an intravenous access. Dexmedetomidine is probably one of the most commonest used drugs, at least as an intravenous infusion. When we require something for a longer term, for hours, or maybe now we use it for beyond 24 hours, for days as well. You can use a loading dose, but there are more complications related to loading dose. We generally avoid that. and we use some other agent in the interim period, maybe a short-acting benzodiazepine or maybe a ketamine, and then continue with dexmedetomidine. And we have the antipsychotic agents. Haloperidol is one of them. Haloperidol is one drug which has been most commonly used for delirium, can be used intravenous or intramuscular, and it's fairly safe in terms of respiratory depression, but caution is exercised when you have a prolonged QT interval. So as a checklist we have, whenever we are using haloperidol, we will have a checklist where it is written the QT interval is normal. If it is abnormal, we avoid this drug. But the problems with the other drugs, like benzodiazepines, is both respiratory depression and hemodynamic compromise. But one of the major benefits of benzodiazepines is the fast onset of action. And in certain conditions, like benzodiazepine withdrawal or alcohol withdrawal, they become the agents of choice. So whenever we have an alcohol withdrawal, we give benzodiazepines. The challenge is to titrate the benzodiazepines because the requirement of the dose may be very, very high, something that we are not used to in our regular practice. So you may have a benzodiazepine being given every 1 hour, 2 hour. Very rarely we have used benzodiazepine infusions with very close monitoring, especially when you are doing it in a non-ventilated patient. And it's best avoided except for maybe acute management of the delirium. So we generally would not use benzodiazepine on a regular basis for other causes of delirium because they have increased incidence of delirium. The use of benzodiazepines per se increases the incidence of delirium. And we have this decision making whether we want to use an infusion or an as needed basis. Both have their advantages and disadvantages. As needed basis is something you again allow the patient to go into delirium, then use a drug and then wait for an effect to occur. With dextem, the almost the dictum is that we start an infusion, continue it for a few hours, a shift or two, look at the level of senses. We might titrate it to maybe a RAS of -1 or so. Zero is idealistic, but that's seldom achievable. And then maybe down titrate the dose, stop the drug, look at for that drug-free interval, how does the patient behave? Sometimes the delirium can resolve within hours, or sometimes it may require a longer period of time where the infusions can continue. Before we do any of this, if the patient is not very agitated, you have time with you, then what we need to do is the non-pharmacological measures, and which is basically both prevention and management. So if you have that subtly withdrawn patient, they are more easy to manage. Then we can do orientation of the patient to time, place, where they are. No, ICU is a very, very disorienting place. You have lights on all the time. You have noises all the time. You have 6 patients in and around. You have somebody who's shouting. You have all the time people walking around you, unfamiliar faces, unfamiliar voices. Sometimes it could be unfamiliar language, and people really feel out of place. With an elderly, this is enough to precipitate a delirium. So what we do is when we have these patients at risk coming to our intensive care, we take this time to just to orient them to where they are, who their caretaker is. They will introduce themselves. When they visit them, we'll introduce ourselves, talk to them, make them feel comfortable, tell them about the clinical condition, tell them what we are doing. If they have pain and anxiety, alleviate them, because pain could be one of the precipitating factors for delirium. Communication is important, and in this communication part, we need to look at language and intelligence barrier both. So we generally would have someone to support us with language, but what we best do is call the family, ask them to talk to the patient, and give us a kind of a picture of how they are doing, whether they are subtly confused, because the subtle confusion, especially with the language barrier, may be very difficult to pick. And optimizing the environment. We are running a campaign of what is called a silent ICU, very difficult. So our beep volumes in the monitors are now very low. The alarm volumes are also tuned to individual patient. So we set, otherwise you have alarms on all the parameters which are on display by default. We will put the alarm volumes, adjust it to our use, but then you'd like alarms to be loud so that we can hear it far away even. And at the same time, this could be very discomforting to the patient. Not only that, the alarm of the nearby patient may also be discomforting to the patient. So it's very difficult. Lights we look at, we put curtains all around, put off the lights, we have night lamps for every patient. Uh, very difficult to optimize the environment, but we sometimes take cues from the patients also. What about improving the sleep-wake cycle? Well, maybe you can use a sedative as well, very difficult, or maybe some alternative agents which are not exactly sedatives, but may be used for inducing sleep. So melatonin is one drug which is very commonly used, available as spray as well, or as tablet, or emeltion is one another drug which is used. We have used dexmedetomidine also as a short infusion nighttime in patients who are at significant risk and have sleep disturbances as well for prevention of delirium. But this choice of pharmacological agent should be very judicious. We would like to cut down on the drugs. Drugs are one common cause for precipitation of delirium. Even unrelated drugs like antibiotics, they may also be associated with delirium. So whenever we have a patient with risk for delirium or actually manifest delirium, the first thing we do is review the drugs and look at what could be a potential drug offending agent, which we can probably avoid. We look at that. One of the elements which is very strongly emphasized is hypoxia. And elderly people, they anyway have low PaO2 levels. They are very prone to hypoxia. If they have a surgical intervention, especially a major surgery, there is potential for atelectasis. They may become very easily hypoxic, especially in the post-operative period. And it's not unusual to see prophylactic oxygen be given to keep the saturation slightly on the safer side. So we may not settle down for saturation of 90, 91 in these patients. Maybe we will look for a saturation of 95 plus so that we are sure that there are no those subclinical episodes of hypoxia or maybe borderline PO2 levels, because this is easily correctable. In patients with hip surgeries, at least in my unit, this is one of the most common things that we do. Look at oxygenation levels. These are elderly people, and maybe supplement with oxygen, otherwise which we would not have done in another patient. Optimize the sleep-wake cycle, as I said. Provide sensory aid systems. So somebody who has hearing defect, give them a hearing aid. Somebody had problems with their vision, you give them their glasses. Engage them in some kind of sensory or visual stimulus like reading. We allow music. Cell phones, very uncommonly, but we do that under observation, because the problem is the security of the phone, the problem that it may go missing, charging it may break even. So we do not allow, but we do have the liberty where we allow patients to have cell phones with them so that they can watch maybe something or maybe talk to someone. But what we do encourage is make phone calls to the family members, including video calls, so that they see familiar faces, familiar people, feel a little comfortable. And when we do that service to the patient, they are thankful as well. So these are very small things. Probably the best we learned it was in COVID, where we were doing this communication very frequently. And we continued on with this trend where we now do allow a little bit of gadgets with the patient. Music players, yes, we do. So they have their headphones on and maybe a music player other than a mobile, so that the patients are somehow kept engaged and we are keeping the senses also engaged. And family time. Ours is an ICU where we have restricted visiting times, but in a delirious patient, we do allow visitors to come more often, maybe stay back with them, talk to the patient, communicate it with them. And this is also important to get the confidence of the family. We need to communicate to the family that the patient is confused, the patient is difficult to care for, that is refusing medicines, that is pulling on his lines and catheters. There is a potential for injury. There could be a hematoma formation. Some of these visually look very bad if the communication has not been correct. So the most important thing which we do with the identification and establishing the diagnosis is communicated immediately to the family. Sometimes they may confabulate. The patients may tell story, oh, last night my food was not served. These people did not allow me to sleep. They kept my hands tied. Some of them may be correct. Some of them may be wrong. And the interpretation of the family, they have left the patient to us. They will have complaints. The major complaints which go to the management is actually about patients who are delirious and who made complaints about care. The family also feels very odd when the care is compromised to whatever reason. They do not understand delirium. For them, it was a conscious oriented patient who came to the unit, and for whatever reasons, he becomes disoriented. So the acceptance among family is very difficult, and communication has to be done both by the nurses and by the doctors who take care of the patient, that the family knows that this is a common condition which occurs. This is how we are managing it. It may be difficult to manage at times, and this is what we are doing to ensure that proper care is provided to the patient. That is all I had to say. I think Saurabh can chip in with his own ways of doing how we are doing, but we would like to just tell you what we do in our intensive care. We have a delirium pathway, and we have a shift note on delirium, which has to be written by the doctor. We look for presence or absence of delirium as done subjectively. Once the doctor notes that there is presence of delirium, then we do the objective assessment and we are using CAM ICU score. That is where the role of the doctor is. As far as the nurse goes, she also does a subjective assessment. As soon as she finds that the patient is confused or there is something wrong, she will immediately escalate the concern to the team leader and to the doctor, both of them. We have a staff nurse who is dedicated to noting all patients who are on delirium to see the CAM ICU score, to look for precipitating factors, associated medical or surgical conditions, to review the drug charts, to review the any new medicine which has been introduced, a possibility of a withdrawal, talk to the family, communicate them about the presence of delirium, and then we take a note of everything that we have done in a sheet, put it in our major diagnosis as well. At the time of discharge, the patient had delirium during the ICU stay, and start for the options of physical as well as chemical restraint. More emphasis on chemical restraint, physical restraint for a short period of time. Although we take a time out of 24 hours, we generally reviewed every shift to see if physical restraint is any longer needed. What we have found out is the identification rates of delirium has increased significantly just with the introduction of a small checklist, just with the introduction of a pathway. Our use of dexmedetomidine has increased significantly, and we have more nurses reporting to us patients who have delirium because they know how challenging it becomes if they have an agitated patient to manage. So delirium is one area where the pathways systems are of great help, and also the alertness about it among the physician community as well as the nursing community is one area which helps us tremendously in managing these patients. That is all I had to say. I think Saurabh is there to give his own inputs, and what does he do and what does he think?
Thank you, Rakesh. You have explained very nicely. And you are also doing excellent work in a hospital to identify and to prevent and treat delirium. Yes, as you said, delirium is quite common actually. Though like around 70 to 80% patient in our ICU may have delirium, and some of them are the symptoms are so subtle that we cannot identify it. And delirium, it does affect adversely the clinical outcomes. It increases the mortality, it increases the hospital stay, it increases the ventilator days. So we need to identify, and it's always better to prevent than the cure. Once it happens, it's difficult. Cannot let the patient to have restless and they are trying to pull out their cannulas and all. So we have to identify at the earliest, and we have to take all the precaution that identify who the patients who are the risk factor of having delirium, and we have to take precautions so that they don't have delirium or hot delirium. And as you rightly said, we have to we have to find out the cause, what will the specific factor that is causing delirium. One of the important factors is inadequate management of pain. That if we let the patient suffer for a long time, it can cause delirium. Again, as you rightly said, when the patient should the patient cannot sleep at in the ICU at night because of the sounds noise of our monitors. And like while structuring ICU, also we should try to make that there's ample of daylights during the daytime. And early mobilization is also very important. You can mobilize the patient early. It also helps to prevent delirium. As you already mentioned, the physical restraint, it should be minimum because physical restraint itself can cause delirium. So you have explained very nicely, and also practically also you're doing excellent job. I want to ask the students if they can type in the chat box if they have any questions.
So one of the areas where we find it very difficult is in ventilated patients, because we use pseudoanalgesia in them. We do drug-free interval, and sometimes it's very confusing what is happening. Is it the residual effect of drugs, or is it delirium? Because if you look at the incidence of delirium in ventilated patients, it's almost like 50 to 80%, very high. Correct. And then we deliberately use a sedative, and then the family is very difficult to convince that it is the effect of the drug which is still residual, or maybe the withdrawal of the drug. Even we use benzodiazepines for 3, 4, 5 days, although the incidence has come down. But I know when you need deep sedation, benzodiazepine is one of the drugs that we use very commonly. We can use it safely for a longer period of time. And in this patient, the other challenge is to label it delirium, because the initial condition is so critical that they may be disoriented at the time of arrival. They may be intubated in the emergency. You do not have a time to assess them very well. And then suddenly you have a condition where they have stabilized, but they have a neuro deficit. We see imaging being done so frequently. And doing an MRI in this patient is a hell of a task, because the agitated patient being taken to the MR suite, or even sometimes the CT, we don't have it bedside, so you always have to be taken. It's very difficult, and it becomes very compelling for us also to do these procedures just to rule out any neurological event which could have occurred. So personally, I find it very difficult in patients who have been on ventilator. And what do we do? Do we continue some of the drugs?
We think of delirium when patient is at the recovery part.
Period.
When patient is very sick, we don't think of delirium. When we try to win the patient from the mechanical ventilation, and when patient is ill, then we think patient may have delirium. It happens like that.
Yes. One thing is for sure, that if you have a established metabolic cause for the neurological issue, do not label it delirium. It doesn't make any sense.
Correct.
And the other thing is, if the patient is really withdrawn, comatose, then also don't make a diagnosis of delirium. RAS -3, they say, I don't know how you can assess delirium at a RAS of -3. We take a cut of -2. Beyond -2, we say, let the expert make an assessment and let him conclude if there is delirium or not.
Yes. Correct. So, any questions?
I can stop sharing, I guess.
Yeah. We have 10 minutes left.
Yeah, now you can see my face. We are both.
Yeah. Nice to see you. Recently, we had a patient. He had severe ARDS, not delirium, not severe ARDS. Like they didn't opt for ECMO. Then we prone him for 7, 8 times, and then after 60 days, we kept him within us about 60 days. Then we finally discharged him with tracheostomy and overnight BiPAP. And this patient, he had critical neuropathy and critical neuropathic myopathy. All is 3 limb. One limb, this power is 5/5, but other 3 limbs, no, it is like 1/5, 2/5 like. So his lungs are recovering, but he ended up in critical care neuropathic myopathy. And we also
we
gave
after
lots of,
we
huh?
yes, continue.
We also gave lots of muscle relaxant initially for
Yes.
prodding and all. Yeah. Mm.
We had a very interesting patient this time because we are keeping a checklist on delirium. So we were
Yeah.
kind of tracking it. You won't believe the patient has a hospitalization of 3 months.
Yeah.
She had a tracheomalacia, which was very interesting, primarily, for which extubation failed, a tracheostomy was done, and the decannulation failed. And
Okay.
that patient had been in delirium for 2 months, which is the highest that I have seen. And we were like almost hell-bent that it was difficult for the attendants to take her home. That is true. You have a tracheostomy tube in place and you're a delirious patient. Very difficult combination to manage. And luckily, it started resolving towards the late part. So much so that she was fully into without any cognitive deficit, because we were concerned also. Patient was on ventilator, whether there was a cognitive deficit because of the hypoxia part. We have a lot of questions to answer. But it was then I realized that probably these issues can go on for months altogether. We do not see those patients months altogether in the hospital, but after going back home, maybe this delirium issue continues. And even for the caregiver at home, there are less number of physical people. It can be very, very difficult. So those are the lessons learned, that we may have these long stay patients. Many of them remain confused. We also remain confused. What is happening? Is it delirium or is it some cognitive deficits? We do battery of tests, try to find out this and that, and then see that we have no other explanation. So we need to appreciate that picking up this problem is important, not only for the outcomes in the hospital itself, but for the long-term health of the patient.
Correct. It's good that you call them after a month to check whether still the component is there or not.
Yeah, because we are keeping them, we are just doing a survey on looking at how many patients actually develop delirium. And you will be surprised that the one best index of our rate was the actual use of dexmedetomidine. The dexmedetomidine use has increased significantly. So much so that nurses come and say, "Sir, dexdem laga dein kya?" So it has come to a point where they report to us very early, and we frequently resort to some or other form of chemical restraint generally. My psychiatrist has started visiting the ICU more, so he also knows what's happening. And he said, "Lord, there is a lot of delirium, and you are being called just to look at whether there could be some kind of pre-existing illness or something." So I think this alert, it's a very easy issue, but very, very difficult to manage delirious patients, and especially use of drugs. You use a benzodiazepine, patient goes into respiratory insufficiency, you have to intubate, or maybe, these are not uncommon situations. So we should be very clear about the pathways that we follow.
Yes. At least we should, like, 2, 3 things we should ensure. At least that the patient should have a good night's sleep in the ICU.
Yes.
He should not be free. Minimum dose of steroid, minimum dose of now we use quetiapine, like we're using quetiapine at night, and we're doing good result.
Saurabh, what are the drugs you are? I wanted to ask this. What are the drugs you are using for sleep in the intensive care?
Quetiapine we use. Quetiapine is a good drug. It's good for it, not very
And what dose are you using?
We're giving 25 to 50 milligram twice daily.
25. Okay. We also started 25.
Initially we started 25 twice daily. Then we increased to 50 milligram twice daily. It's a very good drug. And
anything else that you're using?
Melatonin also we use.
Melatonin you're using? You're using the sprays or the tablets?
Both.
Both. Okay. Okay.
And what about you?
We are using melatonin. We have not used very frequently. Very, very few patients. But we use quetiapine. We are using olanzapine a lot. And we are also using haloperidol a lot. Maybe highest is haloperidol. Second would be probably olanzapine. Third would be probably quetiapine. Very rarely we use the lower dose 5 milligrams. And also We are also
like,
using benzodiazepines. I am
yeah.
very
Benzodiazepine we use less, but I think haloperidol is the most widely used drug all like around the world, both
true.
tablet, IV, every day. Yeah. Tablet also there.
And any issues with Remeltion? Have you used, or is it
Sorry?
available? I don't know. Remeltion?
No, not much.
No, not much. Okay. Ketamine also we use fairly for acute control. That we have started using these days. We use 50 milligram, but we are not going beyond the 50 to 100 milligram dose. That is what we are using.
Okay, I think
So we have one candidate who has raised the hand. If she wants to unmute
Yes.
and speak.
yeah, he can ask the questions. Yes.
Do you have any questions?
Yes.
Please unmute and speak.
Please,
Madam, do
please
you have a
unmute yourself.
question? Madam, do you have a question? Please unmute and speak. You need to unmute.
No?
Yeah.
Yes, sir. Fentanyl is good for. Hello.
Yes,
Yes.
yes.
Okay. This was one question for you.
What do you want to ask? I heard fentanyl. You want to ask something about fentanyl?
Yes, 50 mg. One.
Fentanyl is an excellent agent. Yeah, fentanyl is an excellent agent because it has some sedative property, analgesic property, but we would not use it for management of delirium per se. But if we think like
Okay.
pain is not adequately controlled, and that could be the precipitating cause or maybe the disturbing element for the patient, yes, you can use fentanyl. Always remember, it's still an opioid. Safe or unsafe, it's still an opioid. You have to take all the precautions for use an opioid. And for us, it's a reportable drug. We don't keep it in the unit, so we have to make special requisition. It generally takes 5 minutes for us, for in our unit, for fentanyl to reach us. So when it's very acute need, we are not using fentanyl, but you can use fentanyl if pain is an issue, but not per se for delirium.
Okay. Okay. Thank you so much, sir.
Thank you.
I think Rakesh, there's no more questions.
Yes, yes.
Nice to meet you like this also.
Yeah. Saurabh, we might catch up again on a step session or maybe somewhere else.
Yeah. Okay then. Thank you so
So
much.
I think we are
Thank you.
done. Yeah. Thank you so
It's a
much.
nice talk.
Thank you. Thank you, sir.
Thank you.